So I'm going to talk about psychiatric complications of Parkinson's disease. I happen to be a psychiatrist as well as a neurologist, so this is one of the areas that got me interested in doing both psychiatry and neurology, the degree to which neurological diseases can cause psychiatric problems, because again, as I mentioned, the brain is how we interact with our environment, how we react to it, how we engage with it. And when diseases affect the brain, they affect that ability and the way in which our environment affects us and the way that we choose to or choose not to engage with the environment. So I'll be talking about what some of the psychiatric complications of Parkinson's disease are, a little bit about why they occur, the diagnosis of these problems, and some of the available treatments. Although none of our treatments are where we would want them to be, we are making some advances that I think have been very important for our patients. So I'll give a few caveats and challenges. One is that we in general have a pretty poor understanding of Parkinson's disease. That's not to say we don't understand much about it. There are a lot of things that we understand about Parkinson's disease, but there are a lot of things that we are not quite clear on. And add to that every brain is different. There is nobody in here whose brain has ever existed before or will ever exist again. Even identical twins have different brains. And we're not talking about from the time of birth, we're talking about in utero. So all of the diseases that affect the brain are going to affect different individuals in different ways. Psychiatric complications cause huge reductions in quality of life. In fact, repeated studies have demonstrated that psychiatric complications cause more of an impact than the motor complications and then the cognitive complications of Parkinson's disease. So these are really important, and I think that a lot of people don't realize that Parkinson's disease, the biology of it, sets us up for these psychiatric complications. It is not simply a reaction or sadness about having a change in your ability. In fact, depression in Parkinson's disease and anxiety in Parkinson's disease can occur before any motor symptoms. So that tells us already that it's not people reacting to the fact that they have a tremor or slowed down movement. There's something about the biology of this disease that causes these psychiatric complications. There is some disagreement about exactly how we go about diagnosing these psychiatric complications, although I think there's much better recognition that they do occur and that we need to look out for them. We don't have very good treatments, so even our best agents that we use to treat don't have profound effects. And then we also have considerable safety concerns, not just with the Parkinson complications, the psychiatric complications, but also with the treatments that are used for these complications. So this is a chart that just shows some of the non-motor symptoms of Parkinson's disease. This is just a list of them from something called a non-motor symptom scale. And of those symptoms, of which there are 30, the psychiatric symptoms really tend to dominate. So 50% of people have some trouble with sleep or with feeling nervous. 50% of people seem to be sad. Over 40% lack motivation. Flat mood is over 30%. And even hallucinations and delusions, which seem to be these very severe symptoms and really are severe symptoms, are occurring in over 10% of people with Parkinson's disease. So these are really, really common problems. Why do they occur? You know, Parkinson's disease we think of as being a motor disorder. You reduce the levels of dopamine. Dopamine's important for movement, and therefore you have trouble with movement. So why do you have anxiety, depression, cognitive complications? Well, a lot of this occurs because we are not talking about just a drop in dopamine. Parkinson's disease affects the base of the brain, part of the brain that's important for some of our most basic functions. Because it affects that area of the brain, it affects some of the very small nuclei that produce almost all of the dopamine and another chemical called norepinephrine and another chemical called serotonin that exists in our brains. So you may have heard about these, like they're antidepressants that are called serotonin reuptake inhibitors. Norepinephrine in the central nervous system is pretty much the same as adrenaline, which you may have heard of also. The sources of these neurotransmitters in the brain are in the midbrain and the brain stem, and those are the very areas that Parkinson attacks. So it's not just a dopamine disease, and dopamine is not just involved with movement, but it's also involved with thinking, memory, and emotion. Parkinson's disease, to a great degree, involves desynchronization. So if I want to hold my hand steady like this, there has to be a synchronization between the muscles lifting my arm this way and the muscles pulling them down this way. And when that synchronization is not there, we see tremor. Now, synchronization or synchrony is important across brain processes. And so with desynchronization, which is part of the fundamental kind of teleological nature of Parkinson's disease, you also get similar problems in emotion and thinking. There is an effect, of course, of having a chronic illness and of having disability on one's emotions, so that can't be ignored. And then our treatments also have potential to interfere with our emotions. Dopamine is important in the reward system, and so altering levels of dopamine can cause us to make different decisions based on the reward that we perceive. And then the uncertainty, of course, of Parkinson's disease. Which way is this going? What are the other complications I'll come up with or that will happen to me can also contribute to emotional problems in Parkinson's. So the biggest ones that we see are depression, apathy, anxiety, psychosis, and sleep disorders. Sleep disorders, sort of straddles between a behavioral or psychiatric complication and a physical complication, but I'm going to address that a little bit in my talk. So depression is the most common psychiatric complication of Parkinson's disease. It occurs in about 3/4 of individuals with Parkinson's disease. Sometimes, as I mentioned, people can show up with depression as the first symptom of their Parkinson's disease, and we don't realize they have Parkinson's disease until months or even years down the road when they finally develop motor symptoms. Depression, the likelihood of getting depression seems to be correlated with how severe Parkinson's disease is, in other words, how severe the motor problems are. There's a higher rate of depression in people with cognitive dysfunction. We think that probably represents an overall degeneration of brain processing. People who have anxiety or psychosis with Parkinson's disease are also more likely to have depression. So the symptoms of depression include alteration in sleep pattern, reduced interest in activities that you used to find enjoyable, feelings of guilt or worthlessness or regret. Sometimes that takes the form of ruminations. Poor energy, so that can be either not having to get up and go to do things that you did before, or running out of energy a lot quicker than you used to. Diminished concentration also occurs with depression. So that's an inability to kind of focus on something for a sustained period of time. It sometimes manifests also as struggling with decision making, not being able to make decisions about things that were previously simple. Which shirt should I wear? Should I go to this party or not? Changes in appetite, that can be either increased appetite or decreased appetite. And actually, I should say that this particular criterion does not just include appetite, but also weight loss or weight gain of more than 15% without any other explanation. Slowing down, which is called psychomotor retardation, so slowing down of movement or thinking, or speeding up, jitteriness and agitation. And then thoughts of death. Those can take the most extreme form, which is wanting to die or planning ways to kill yourself, but can also be milder forms, thinking a lot about friends who have died, or thinking about your own death, or what are you going to do when a loved one dies, and being preoccupied with those thoughts. So there are pretty clear symptoms, but this is not a straightforward diagnosis to make of depression. And it becomes particularly difficult because Parkinson's disease symptoms include a lot of these depression symptoms. So sleep deprivation or sleep changes occur in over 90% of people with Parkinson's disease. We see reduced appetite all the time, and in particular, we see reduced weight, especially as people's disease advances. Reduced energy is common. Obviously, slowing down is one of the symptoms of Parkinson's disease, the bradykinesia. You can sometimes interpret tremor as being jitteriness. So it's really not easy to make the diagnosis, and it requires a careful evaluation of all of these symptoms, the way in which they developed. Did they sort of develop together, in which case you might be thinking more that it's depression? Did they come along separately at different stages, in which case it may be more related to the Parkinson's disease process itself? And most importantly, what is the mood state? If the person is sad or unable to feel pleasure, then you're much more likely to be looking at depression than just Parkinson's symptoms. Depression, fortunately, is something that we can treat. Most patients, though not all, will respond to antidepressant treatment. In Parkinson's disease, the rate of response tends to be somewhat lower than we see in run-of-the-mill depression. And in fact, sometimes it's the fact that someone's depression doesn't respond that starts to cue us into the fact that they may have a neurodegenerative disorder. So it turns out that optimizing the treatment of motor symptoms is actually an effective way to get at depression and Parkinson's disease. If someone with Parkinson's disease is depressed, but their motor symptoms are still pretty prominent and they're not on the best treatment they can be on for the motor symptoms, then the motor symptoms need to be optimized. That seems to actually be associated with an improvement in mood and depression symptoms. We can also use the same antidepressants that we use to treat the general population that has depression. Serotonin reuptake inhibitors, which are SSRIs, serotonin and norepinephrine reuptake inhibitors, or SNRIs, and there are other medications that have different ways of working. There isn't a clear difference between the effectiveness of different antidepressants, with the exception that some of the older antidepressants, called tricyclics, have shown benefit in trials directly head-to-head against the SSRIs. So those include nortriptyline, or Pamelor, and desipramine, or norpramine. Those were tried head-to-head against SSRIs and actually produced better improvement in depression. The downside is that those medicines are anticholinergic, and as you just heard from Dr. Blewett, the reduction in acetylcholine or cholinergic signaling is something that can interfere with cognition. So they have to be used with caution, and you want to do a cognitive assessment before starting treatment with a tricyclic and then afterward. And there's been a fair amount of evidence from studies that some of the medicines that we use to treat Parkinson's disease itself, the dopamine agonists, pramipexole, ropinirole, rotigotine, that those medications can have some benefit for depression and Parkinson's disease as well. Apathy is also seen in Parkinson's disease and a lot of neurodegenerative disorders. Happens to about half of people with Parkinson's disease. The symptoms are really split into three categories: behavioral, cognitive, and emotional. And you want to think of apathy as a tendency to kind of reduce and withdraw. So the behavioral components of apathy would include less initiative, not as eager to start on a new endeavor, a new project, even to get started with one's day. Once you do get started, you tend not to be as persistent in going through and completing an activity. I sometimes think of apathy as being kind of like, if there's a rock in the road, you can get that rock's not going to move itself, right? If you kick it, it'll roll for a while, it'll get moving, but if you don't add any further energy to it, it'll just slow down and it'll stop. And that's kind of what apathy is like. There has to be sort of continuous external push to get the individual with apathy to do things. There's also a reduction in cognitive activity. So people with apathy will tend not to be as interested in new ideas, not as interested in engaging with new people. And then there's diminished emotion. not as much reactivity to events that go on, both positive and negative. And also you can see less facial expression, which of course can be difficult to distinguish in Parkinson's disease because of the reduction of facial expression that comes from the illness itself. Apathy is not the same as depression. Clearly, we can see apathy in depression, but people can have apathy without being depressed. And it's very odd for us to see because most of the time when we see apathy, it's associated with depression or some other psychiatric illness. But apathy can occur all by itself in Parkinson's disease. A couple of ways to distinguish apathy from depression. Patients with apathy tend to be pretty content. In fact, one of my patients with the most severe apathy that I've seen was actually one of my happiest patients also. She was just really happy because she was able to watch TV all day, and that's all she wanted to do. I have another patient who literally stays in bed. He gets his meals brought to him and everything. The only things he wants to do, he likes to drive his wife places, but otherwise he says that staying in bed is what I've always wanted to do my whole life. And it's very hard to believe that this person is serious, but that is exactly what happens in apathy. There's this reduction of the desire to seek newness and novelty. And then usually with apathy, we don't see those symptoms of sleep disturbance, appetite disturbance and weight loss, the jitteriness or the psychomotor retardation. So what we call neurovegetative symptoms of depression are not present in people with apathy. These are some guidelines. It doesn't mean that it's easy to distinguish between the two. Very often I will say, listen, I'm not sure what this is. Apathy is difficult to treat. It doesn't respond very well. Our best agents for apathy, we see response rates of between 15 and 30% compared to placebo. But because depression is treatable, if I can't tell the difference, I will usually try and treat for depression. And if we just don't see a response and it really looks like a depression, then we'll halt the treatment. If we don't see a response and it really does look like apathy, then we'll just halt the treatment. But I would say that if you can't tell, it's probably better to err on the side, at least these days, of treatment because the medications are relatively benign for treating depression. Anxiety, another common issue in Parkinson's disease. Anxiety is a normal brain and body function. When we're confronted with danger, what we're supposed to do is either figure out how to confront that danger or escape from that danger. And at the time when the danger is in front of us, that's all we should be thinking about, right? If a tiger jumps out in front of you, your shopping list becomes a little less important, or it should. The problem is that sometimes that system, that normal system, gets hijacked. And we perceive danger, we perceive risk in places where there is no real risk, or we dramatically overestimate the risk. And this can take a bunch of forms. So you can have generalized anxiety, where just all the time you're kind of on edge, you're tense, you're worried about things, you can't seem to get rid of worrisome thoughts that are in the head, tendency to catastrophize. Oh, my wife hasn't come home when she said she would. It's half an hour past that. There must be some terrible accident. I'm going to call the police, or I'm going to stew and fret about it. Obsessive compulsive disorder. So obsessions are unbidden, preoccupying, negative thoughts that you just can't get rid of. And compulsions are behaviors that we engage in to either get rid of thoughts like that or to get rid of anxiety. We see these in Parkinson's disease also. Phobias, which is fear of a specific thing, social phobia, claustrophobia, fear of being in a closed place, and then panic attacks, which are sudden attacks of severe anxiety, as if a tiger just jumped out in front of you, but with no tiger there. All of these occur in Parkinson's disease. All of these occur at higher rates in Parkinson's disease than in the general population, and we think all of them are related to a decrease in the serotonin coming out of the brainstem. These seem to have the most impact on quality of life of all of the psychiatric complications, which you can imagine. If you're living in a state of fear, fear is a pretty significant motivator. And it can be a positive motivator, can make you do things that you wouldn't ordinarily do. And it can be a negative motivator, which is the way it usually manifests in Parkinson's disease, preventing you from doing things that you ought to or want to do. The treatments haven't been well studied. It seems that people are more likely to have anxiety if they have more off time. So again, optimizing the motor symptoms is going to be important. We treat anxiety in the general population with those same medicines that we use for anxiety, and they seem to be effective in the case series and small studies that have been done in Parkinson's disease. And then benzodiazepines, these medicines that are used to help us relax. A lot of them end with PAM or LAM, alprazolam, which is Xanax, clonazepam, Klonopin. Those medicines can be very effective for anxiety but have their potential complications. And psychotic symptoms. So a note on the term psychotic. When we talk about psychosis in medicine, we don't, or at least we try not to use it in a pejorative sense. Psychotic has a specific technical meaning which is related to one's interaction with reality. So psychosis means that for some reason the connection with reality has been weakened or broken. So we see this in 25 to 50% of people with Parkinson's disease. Tends to occur more as the disease advances. So the longer you've had PD, if you had cognitive dysfunction, the older you are, and the worse your motor impairment, the more likely you are to have psychotic symptoms, and we'll talk about specifically what those are. Medications can also induce or worsen psychotic symptoms, particularly the dopamine agonists, and a reduction in vision can actually cause more psychotic symptoms. So the most common psychotic symptoms we see in Parkinson's disease are hallucinations. These are abnormal sensory experiences. In Parkinson's disease, they typically take a visual form. So essentially, your eyes are playing tricks on you. You see something that, based on all other information, including people around you, is not actually there. Usually these hallucinations are well formed. Again, this is something that distinguishes the hallucinations in Parkinson's disease and Lewy body agonists, which can cause people to have sleep attacks where they suddenly and unexpectedly fall asleep. So we discovered this back when these medicines first came out, that people were having car accidents. They'd be driving along feeling just fine, and the next thing they know, they hear a loud crash and they're waking up. So these sleep attacks can be risky, and it's important to be aware of that with the medications. Sometimes the daytime sleepiness is so troublesome that we have to use stimulant medications to reduce the sleepiness. Restless leg syndrome is something that's experienced by a lot of people with Parkinson's disease. So this is an uncomfortable sensation, usually in the legs, but can actually be in any body part. So there are reports of restless abdomen syndrome and restless arms. This is an uncomfortable sensation that usually comes on when people are at rest, and it's relieved with movement. It tends to occur in a circadian pattern, most of the time being worse at night. And treatments for this include the medicines that we use to treat Parkinson's, dopamine agonists and levodopa, as well as some other medicines, gabapentin, pregabalin. Importantly, people who are iron deficient can develop restless leg syndrome, so you should get iron checked if you develop this symptom. Replacement of iron can be helpful, but iron supplementation in people who are not iron deficient, to my understanding, does not seem to help. Periodic leg movements during sleep. So this is while people are asleep now, their legs will kick. It's usually a movement like this, flexion at the ankle and then sometimes flexion at the knee and hip, and it just keeps occurring while they're sleeping. Patients usually aren't aware. It's usually the bed partner that gets bothered by this, and it needs to be diagnosed with a sleep study. We treat it in ways similar to what we do with restless legs. We think that the two syndromes are probably related. And then one of the most dramatic sleep disturbances is REM behavior disorder, which was mentioned by Dr. Blewett. Normally, when we sleep and when we dream, our muscles are essentially paralyzed. Imagine if you went through your dreams and you were moving in reality as you were in your dream. Well, that's what REM behavior disorder is. It's dream enactment. Again, this is something that patients tend not to be aware of unless they wake up like on the floor or in the living room. Or I had one fellow who I asked him if he acts out his dreams at night. He said, I don't know, but like 4 or 5 times a week I wake up and my curtains have been pulled down and my pillows are in the hallway. I said, you probably are. This is actually dangerous. Sometimes people will punch their bed partners, or they will get up and walk off the edge of the stairs, or walk into something harmful, or trip over something. So we really try to get this under control. Fortunately, it is pretty amenable to treatment. Melatonin, the supplement, can work for REM behavior disorder. Another effective treatment is clonazepam. So the important things that I want you to take home from all of these words, these symptoms are very common and very varied. And we really need our patients to talk to us about these symptoms. I like to tell my patients, if the thought comes to your head, I wonder if I should call Dr. Wint about this, the answer to that question is always yes. And the reason is that it's my job and my colleagues' jobs to know whether what you're experiencing is related to the illness for which I treat you. It's not your job to try and figure that out. What we want to know is what you're experiencing that's impacting your quality of life, and then we try and figure out how to help you with that. And it may not be us that can help you, it may be your cardiologist or your rheumatologist or someone else, but we'd much rather hear about it and it not be our problem than for you to come in for your 3-month appointment and tell me that for the past 2 months you've been having REM behavior disorder and the reason you're in a wheelchair is because you fell down the stairs during one of those episodes. We don't have any magical way of knowing that you have these symptoms. Yes, we try to ask, and my colleagues in the movement disorders are particularly good at that. They have a list of standardized questions that they ask. But remember, every individual brain is different. And so the same disease affects individuals in different ways. And on top of that, these diseases manifest very differently. Someone with Parkinson's disease, person A, and person B may have different patterns of pathology in their brains, and their brains are different already. So we need to know what's going on with you as an individual before we can figure out how to help you as an individual. And then stick with it. The first, the second, even the third treatment may not work for the problem that you have, but it's important to try and get it treated. Thank you very much.